Okay, so first of all, I would like to thank the jury here in Quantum Effects for choosing us to award us with the prize of quantum sensing in a field like with such smart people around us, like the guys from Qnami are sitting here next to us. A field of such smart people working so hard to develop and translate quantum technologies, quantum sensing technologies into products. This is a huge honor, and we're very proud for this. I'll explain to you more about what we do exactly and what quantum hyperpolarization means. So Envision was founded by a mix of business entrepreneurs and quantum physicists from the University of Ulm in Germany. So we are here from Beauvais, born in Beauvais, operating in Beauvais, headquartered in Beauvais. The three quantum physicists who co-founded the company are Professor Fedor Jelecko, Professor Martin Plenio, and Professor Alex Retzker. All three of them leading figures in the field of quantum physics, quantum manipulation. And then Eli Schwartz and myself joining forces with them from the business side, medical side, R&D side, to complement each other. That's the team now. We started in 2017 with just as a company with the concept of taking quantum technologies into a real material product. This is the team today. This is from 2022. We're now almost 70 people, a combination of physicists, chemists, material scientists, and now more and more people on the commercial side, general managers, product developers, regulatory experts, clinical experts, to really take the quantum side and translate this into real life use. It's also a very multinational team. We have people coming from more than 10 different countries, or born in 10 different countries, who co-located with us in Ulm in order to build this technology. So it's a group of dreamers and very interdisciplinary one. We're very fortunate to receive funding from not just private investors who believed in us, but also, of course, from the state of Baden-Württemberg, from the federal government of Germany, from the BMBF, and lastly, of course, funding that we've received through the Quantum Flagship from the European Commission. I want to emphasize that without such funding, these kind of ventures, in our perspectives, are impossible. So the enabler to be here today, a company of 70 people who are commercializing and about to launch products to the market, is only thanks to such support from the state, the government, and the European Commission. What we're doing is we're about to release actual products, physical products. The one you see here is the first to go to market early next year. It's called a polarizer, or a quantum polarizer, and we'll explain what it does. In essence, it really enables MRIs to take a leap into the future and becoming much more powerful than they are today. And I'll explain how. So I'll just focus on our main application, right? At the end of the day, quantum is it can bring power to many applications. The question is, what problem are you trying to solve, right? It's not enough to have just to have great technology. You don't want to look for a problem. You really want to make sure you have the solution that addresses the specific problem. And the problem that we're trying to focus here on is the inability of anatomical-based imaging of standard MRIs to assess treatment efficacy, to assess whether treatment is helpful or not in short time frames. So it's for the first time in history, we have more options than time to try them. We have twice as many novel drugs coming to market than we had in 2016. But at the same time, despite the fact that we have more options, it still takes a long time to try them, to try these options. So until today, still, a course of therapy takes 4 to 6 months. And that's exactly what we're trying to change in order to allow patients to be able to receive the drugs that are best fitted for them based on not whether they're supposed to work, but are they actually working? And we'll explain what that means. Because patients don't have the time to wait. If we're looking at metastatic breast cancer patients, they still have 9 to 12 months to live. while the course of therapy takes 4 to 6 months. And this dissonance is what we're trying to solve here. So what is the standard? What's the standard course of therapy? You diagnose the patient and you look for markers, those genomic markers, proteomic-based markers, markers that are telling you that there is a certain treatment that's likely to work. And then you start the treatment and you go through several courses of chemotherapy. Usually they take 4 to 6 months at least. And at the end, only months later, you actually get the feedback using imaging. And imaging, hands down, is the most common way to assess treatment efficacy. That is the mainstay. This is how it's done in every hospital. You start treatment, you wait, and 4 to 6 months later, you see the anatomical changes, the structural changes. These take a long time to happen. The reason that they take very long time to happen is that the first thing that would happen after you initiated effective treatment is that weeks later, you start seeing cell death. You start seeing enough cell death, tumor cell death, to actually start getting any impact. By the time you see the actual structural changes, and when I'm saying structural changes, I mean that the tumor is smaller, it shrinks, the volume is reduced. And reduction in the volume of tumor is today the most obvious way, or the only obvious way to assess whether treatment is working or not. But for us to see those structural changes in volume, that would take months to do today with standard MRIs, standard CTs, anything that just measures the anatomy. The things that would happen much earlier when treatment hits the target are changes in the metabolism of the tumor. So we know that metabolism is the engine. This is how tumors generate their energy. This is how they continue to grow. This is how they continue to live. This is how they continue to evade the immune system, by generating energy for themselves. And if you know how, if you can assess whether you're hitting the tumor metabolism, if you're interfering with the engine, right? You're hitting the engine. That's the fastest way to know that you're actually going to stop that tumor from driving forward. Okay? Imagine a car. You can damage a car. You can still move forward. It's only if you're hitting the engine of the car that this car stops. And that's exactly what we're trying to assess, whether treatment is hitting the engine, whether treatment is hitting the way that tumors use energy, and sugar specifically. So what we're going to offer to clinicians is a zoom out. Instead of looking at the anatomical features, right, the structures, we're going to zoom them into the metabolic pathways. They're going to be able to look into whether metabolism is being impacted by treatment. And when I say metabolism, is how they're using sugars. Okay? How, if you give a tumor a sugar, is it using it correct? Is it using it as you would anticipate that it's using it, or has this tumor been affected by treatment in a way that it is now not using sugar in the way it should be, that the engine is now damaged? And to access this information, it is impossible to access it using standard MRIs. MRIs are a wonderful tool. They're ubiquitous, they're everywhere. We have 50,000 MRIs out there. Every hospital almost has one. We have millions, tens of millions of scans annually. They're indispensable to many fields of medicine, and they're very safe. There's no ionizing radiation. There's no X-rays. It's all based on magnetic resonance, based on the magnetic properties of water. So if you're thinking about what MRI is basically a tool that tells you where do you have water in your body and how the water are affected by the tissues around them. So MRI tells you there's water here, and it looks like water in muscle, and that means that this is muscle. Or this is how water would look in the blood, and this is the blood. So that, based on the signal of water, which we have so much of it in our bodies, the MRIs are able to create the anatomical structural image. But they are not sensitive enough to detect any other small molecule in our bodies that we are calling metabolites, so sugars. They're unable to detect other molecules that are entering the cell, except from water. Again, because we have so much water it's enough signal. But if you're thinking about how little sugar is eventually going into the cells, to the tumor cells, MRIs are unable to detect it because they're not sensitive enough. And what we're solving is exactly this. We're using quantum hyperpolarization to enhance the signal of sugars. And this is how it works. You take sugar that you want to use to visualize because you know that this is the fuel that cancers use. They take a lot of sugar to grow and to survive. You take that sugar and you put it in the polarizer, in the quantum polarizer. The quantum polarizer does quantum manipulation. Basically takes the nuclear spins of the sugar, right? Like every other molecule that we have, it has nuclear spins, and it orients them in a single direction. Instead of them being randomly distributed, it orients them in a single direction. And this orientation then translates to MRI signal. You can think about it as we're magnetizing a molecule. We're making its nuclear spins orient in a single direction. And that, again, that direction, that orientation translates to MRI signal. Because the MRI is sensitive to the magnetic properties, as we mentioned. Then this sugar that's now polarized and behaves in the natural way that nature intended it to behave, it's just magnetized. This sugar is then taken and injected will be injected into the patients. Right now we're doing this in animals. We'll talk about it. It's injected into the patient, and then using the signal coming from the sugar, the MRI every standard MRI can detect that signal and analyze how the tumor is using it. So remember that scheme. We said we're using sugar. Specific sugar that we're using is called pyruvate. Pyruvate goes into the tumor cell and then can transform into the downstream metabolites. And what the MRI does once it's able to, because the signal is so strong, we're enhancing the signal almost 100,000 times compared to the baseline because of the magnetization. It's able to track that pyruvate that now lights up to the MRI and observe it as it turns into other metabolites. So it's basically tracking it as it goes through the metabolic cascades and creates a metabolic analysis almost on a cell-by-cell level. All right? So instead of looking at structures, we're zooming in into the cell level. And you can think about it as the difference between Google Maps and Google Earth, right? Or Google Street. When you're zooming in and you're looking into the street level. That's exactly what we're doing. We're having the anatomical map and we're zooming in, looking into the metabolic behavior. And we're using the spectral capabilities of the MRI to create those metabolic signatures. And then you don't need to be a rocket scientist as a radiologist to read the image. What you do is basically looking at a heat map. We're analyzing the data and providing a heat map of where do you have areas of higher metabolism, lower metabolism, and then you are able to track it over time, of course, as you are administering treatment. And I'll show you what we mean. So here's an example of a tumor. These are images that were acquired at the Technical University of Munich with our polarizer at the Klinikum Recht der Isar, where they took our polarizer, used it with their animal MRI, and looked into whether they can detect tumors and their activity, and whether they can detect tumor death. All right, where areas where tumors are no longer using sugars because the engine is dead. So you can see here, you can see over here, this is a tumor, and it's very difficult to say in this mess, is this tumor now reacting to treatment or not reacting to treatment based on the structures. And this is a tumor that was just a new tumor in a mouse model. It's a human tumor in a mouse. And you can see that we are able to detect in less than a sub-centimetric level, we're able to detect whether this tumor is viable or not. Is it still alive or not? Is it still metabolizing sugar or not? So you can see here clearly, I mean, not on a screen in front of the whole, with this light outside, but on a computer screen, you can really see clearly in a sub-centimetric level resolution areas of where tumor is already dead, responding to treatment, versus areas that the tumor is still viable. So you can see the tumor heterogeneity in terms of the treatment response. Okay? And that is something that you're completely unable to do with an anatomical image. All right? So looking at the metabolism of the tumor instead of the shape of the tumor. Looking at the cell level instead of the tissue level. And where would that lead us? The important thing here, we did not develop a marker. We're not trying to anticipate who's going to respond and then let nature decide. We're looking at what's actually happening. We're not flipping a coin. We're looking at what's actually happening once you start a treatment. So the paradigm that we're trying to deploy here with our collaborators worldwide, starting in Germany with Technical University of Munich, with Uniklinik Freiburg, Uniklinik Ulm, as example of close collaborators, is to start assessing the patient first for the baseline metabolism, look at the tumor, how it behaves metabolically before the treatment, start treatment, and then instead of waiting the months that people waited before because they wanted to see the tumor shrinks, right, things that are very slow changing, we are looking, after less than 7 days, we'll be looking at metabolism as it changes in real time. We will look whether treatment is working or not based on the metabolic effects, not based on the anatomical effects that are slow. And that could be achieved in 7 days, we believe. And early studies show that this is extremely feasible. There are studies showing that in less than 4 days, you'll be able to assess whether treatment is hitting the target or not based just on the metabolic effects that we can anticipate, because we know how the treatment should behave, we know the effects it should have on metabolism. And then, once you know it's working or not, you course correct. If you have different type, if there is the population of patients that are sensitive to the tumor would continue receiving the same treatment. Sorry, sensitive to the treatment will continue to receive the same treatment, while populations that are not sensitive will either be escalated to other treatments, different treatments, additional treatments, or could be a decision not to treat this patient at all because if there's no alternative, then there's also no benefit of creating the toxicity that comes with it. And the effect on that would have, it's kind of a very multi-layer effect, what the impact could be on healthcare systems. So first of all, of course, better efficacy, because if you can tailor the treatment that works, you can define what treatment works versus not, of course, eventually in this Venn diagram, you'll get more patients receiving treatment that's effective for them. The second thing is, I mentioned reduced toxicity. Sometimes you're giving the treatment, and you don't really have other alternatives, or you have surgical alternatives, or you have other alternatives that are outside of the chemotherapy or the immunotherapy and so on. If there is no impact, there is no benefit of giving the treatment, you might as well stop the treatment and not cause all the toxicity that comes with it. And it's a big deal in many types of therapies. You can also decide, let's start with treatment that is less toxic, see if that works alone, and only then decide to add the cytotoxic therapy. So that has impact on less toxicity. And of course, cost. With more drugs, more innovative drugs, this comes at a huge cost to the healthcare systems. Immunotherapies can cost $80K a year per patient. We want to decrease that cost in making sure that great drugs make it to patients, but only if they're helpful. There are additional benefits that this could bring to almost every area of medicine. So oncology is just one example. Cancer is just one example. But metabolism is in the essence of every type of disease, be that cardiology and hepatology in the liver, and nephrology in the kidneys, and neurology in the brain, and rheumatology, any inflammatory diseases. So metabolism is in the essence. It's part of these diseases. So you can think about the same measures, instead of being used in cancer, being used in these other therapeutic areas. And we're looking into this with our collaborators in different centers in the world. How does it, I want to go into what's the quantum part of it, right? Why is it quantum? Okay, and remember, we just won the prize for quantum sensing, but in that sense, we are not a traditional quantum sensing company because we're not creating the sensor ourselves. We're using the MRI as the sensor. But the MRI is able to detect those quantum effects all right, that magnetization. And what we're doing, we're just increasing the signal of the sugars for the MRI. We're not developing the sensor. The sensor is the MRIs that every hospital already has. And how does it work? So we're using hydrogen gas. And hydrogen gas has this amazing feature in which we can basically charge it with magnetization, charge it with polarization, in a way that we can just take it around, move it around, ship it to hospitals, and let them use it as a source of polarization, kind of a battery for magnetization. It's a really interesting feature of hydrogen, where you can bring it to a quantum state called parahydrogen that allows you to store magnetization or polarization for very long periods of time at room temperature, and you can move it around and ship it. So we're shipping this specialized hydrogen to the hospitals. In the hospital, there is a system. The system is the quantum polarizer that you see, that I showed you before. This quantum polarizer basically takes the hydrogen, right? Takes the hydrogen charged with the magnetization, with the polarization, and just transfers the polarization from the hydrogen to the molecule of choice. And that is done by getting the hydrogen molecules, the specialized hydrogen molecules, very close to the molecule by hydrogenating it. And then with a very tight control of 5-spin system, a 5-qubit system, we're able to transfer the polarization from the hydrogen, that's better to use, from the hydrogen all the way to the carbon that we would like to magnetize. And that carbon eventually keeps this magnetization in a way that allows us to use it in the MRI. Okay? So that's the quantum part. The quantum part is that to control this system, you have to have an extremely deep understanding of how quantum manipulation works and how quantum physics works, in order to charge the hydrogen in a way that lasts for a long time, get it to this user, and then transfer the polarization using all the quantum dynamics secret sauce from the hydrogen into the carbon atom that we would like to use for visualization in the MRI. So that magnetization transfer. In terms of our go-to-market, this is our first system that we've built in-house, our homegrown system. We've demonstrated it in the industrial environment, in the University of Ulm, in the Technical University of Munich. And with that proof of concept, with that demonstration, we went to the commercial phase. And these are the first systems that will be launched in 2024 to hospitals across Europe and the US, most likely also in Asia. And this is a second system coming a year later that has a quality control unit that allows it to be also injected to humans in a safely manner. We're doing the manufacturing. It's a very kind of European project at the end. We're doing the manufacturing with a Dutch partner, bringing all the knowledge that we've built here into a material, real product for clinical use. I wanted to mention one of the projects that we are most proud of. It is the quantum sensing lighthouse of the German government, sponsored by the BMBF. It's a project that brings together all the stakeholders needed to create the signal, the polarization, acquire it on the MRI, and then use it clinically. So we have Envision as the coordinator doing the polarization. We have Siemens Healthineers, the biggest leader, the leader of MRI scanners in the world, over 40% of the market share, together with Rabbit Biomedical, a company making MRI coils from Würzburg, together with another quantum company called Cruise, also here from Jülich, and three hospitals, by coincidence in the southern part of Germany, that are going to use this using this for showing the clinical impact, bringing this to human injections, to run actual clinical trials with this, and then spreading it out to further in Germany, Europe, and globally. These are the centers that we are working right now to place our systems with. You can see they are not restricted to, these are just examples, they're not restricted just to the continental Europe, UK, but also to the US. And as I've mentioned now, there is demand coming from Asia, and we're expecting this to be a very global footprint within the next 18 months to 24 months. That's it on the MRI side. I would like to mention the fact that, remember I told you what else is coming for us as a company. Despite we're making huge progress there on translating these technologies, taking using our capacity as researchers. We've got wonderful researchers in our company, quantum physicists, material scientists, chemists who are experts in building systems or engineered for quantum use. So what's next for us as a company besides taking all this technology into the market? How do we leverage our expertise in research? And that's what's coming next. So remember I told you, in order to get the polarization, we're using a 5-qubit system, a 5-spin system, where we transfer the polarization from the hydrogen into the carbon. We understand how to control qubits, how to control spins, how to make this process extremely efficient and well controlled. So we're routing a lot of our internal minds, internal research capacity right now to taking this further, taking that ability to control 5-qubit spins really, really well into the thousands of qubit spins, and hopefully one day millions of qubits, in order to develop capabilities in quantum computing. It's not just a buzzword. We really have the ability, and we really believe in our approach, in a unique approach and a refreshing approach to quantum computing. I will not share much, but I will use this as a teaser for what's coming into the future. So if you're thinking about quantum computing as a matrix between number of qubits and control, we currently are using a low number of qubit system, which we control really well in order to already deliver the first application in MRI. Something we took from a concept level and brought it into an actual product. We're planning to do the same here, but with a larger number of qubits, above the 1,000, above the million, hopefully one day, to use the same level of control at a higher number of qubits to bring a new approach, a new refreshing approach to quantum computing, which we call PIXI, which stands for photo-induced quantum computing. Just as a teaser for something that's coming up in the future, I believe as a company that brought something from a conceptual level, something that was barely a patent, into an actual product, we're quite well positioned to bring our minds and hearts and the motivation of our team to be thinking about new products for the future in quantum. That's it. Thank you.